Dr. Gwon, please
Yeah.
start your case.
Okay, welcome to Samsung Medical Center. I'm Hyun-Chul Gwon from Samsung Medical Center, and the second operator is Young-Bin Song in our hospital. And third operator, On-Yu Kim, our third fellowship trainees. Okay, Dr. Kim, can you please present today's case?
Good afternoon, everyone. My name is On-Yu Kim. I will present the live case of complex coronary lesion treated with drug-coated balloon. Next. This is the 82-year-old female who presented with the exogenous dyspnea for 6 months and had a severe chest pain 20 days ago. Her past medical history includes the hypertension, diabetes, hyperdyslipidemia, and chronic kidney disease with the EGFR22. At the outside hospital, coronary angiography was performed. It shows the distal RCA thrombotic occlusion and significant stenosis at mid-LAD bifurcation lesion. Next. Electrocardiogram showed the right bundle branch block. Next. Echocardiography revealed the mild airway systolic dysfunction with regional wall motion abnormality, and aneurysmal change was noted at inferior wall. Next. This is the coronary angiography from the outside hospital. There is thrombotic occlusion at distal RCA and significant stenosis at mid-LAD bifurcation lesion, Medina 111. Next. The patient met the high bleeding risk according to the ARC-HBR criteria. The patient had severe CKD as one major criteria, and being aged 82 years as a minor criteria. Next. The precise depth score of the patient is 56, indicating the high bleeding risk. Next.
Okay, please show us the EKG. Second slide. Okay. This you can see the Q wave in the 2-3 AVF suggesting infarct, and more importantly, you can see ST elevation in 3 leads that suggesting aneurysmal dilatation of inferior wall. So next, the echocardiography also showed aneurysmal dilatation. So RCA territory is in my mind is the scar change and the non-viable myocardium. So I don't like to treat the right coronary artery. Next. 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 So 82 years old female patient. There's a small body size. And actually, I asked the patient today, and how have you been? Okay, no, not so much. I'm doing my whole homework, whole home job, and doing laundries and a lot of things, but I had no discomfort at all. This is a typical type of old age, but he can, if he walk out the street and walk up the stairs, he might have some dyspnea and the limitation of exercise. So this is an HBL patient. I like to treat this patient as conservative as possible. And so this is a true bifurcation LAD. Maybe you think about two-stand technique, or this is, you can see here, very highly calcified lesion, right? This is very unlikely to end up with the balloon itself. A stent is needed, but the calcifications all around the LAD. So I like to end up with, finish with just a DCB for both branch. For that purpose, lesion preparation is really important. So we can consider cutting balloon, NC balloon, rotablation, RBL. And so I'd like to show today's, next slide, please. Next slide. So currently, Dr. Junyoung Lee is leading a DCB HBL trial. He enrolled about almost 1,400 patients randomized to a DCB versus DES. And the enrollment was achieved almost 95%, almost done. It's very interesting. But mostly, this kind of lesion is very simple lesion, right? So I don't know, it can be applied to a calcified bifurcation lesion. I'm exploring the new possibility of a DCB. I'm not sure it will be successful or not. So creatine level is 2.0, 2.1, and eGFR 22. We are very careful not to overuse contrast dye. The angiography on the screen, please. Angiography.
Today's
angiography, please. It's coming. Okay, today's angiography. You can see a lot of calcification from LAD2, from osteomer LAD2 down to mid LAD. And diagonal is also calcified. When you carefully, next slide, and this is epicranial, we got just two views, and the spanning 12 millimeter of the contrast dye. And this is very tight lesion. The problem is that the lesion is, LAD is covered with calcification. Even with a stent, I think that there is a high risk of edge dissection. So, what do you think?
May I have one question?
Yep.
Did you ask the patient, you have a possibility of hemodialysis 3 times a week after the PCI? It is not an issue for the bleeding or the coronary event. You know, in the elderly patient, it's a hemodialysis.
Right.
It's critical.
Yeah, right. Yeah, I talked about that. I tell the patient that the possibility, but in our center, actually, we had a study in the patient with CKD about contrast-induced nephropathy. The diabetes with the creatine 2.0, there is about 20% risk of the increased CIN. So this is a high-risk patient, but we meticulously prepared this patient with hydration, with some diuretics. I think there is a risk of HD, but actually not that much. About
Is
10%.
the overall patient, is that specifically in the elderly patient, that possibility is more higher.
Yeah.
So even though we use the small amount of the contrast in the elderly patient, easy to have shift to the.
You prefer a zero contrast PCI, right?
No, anyhow, we have the best. So to view, no, you'd better to just a single one injection.
I try to finish the procedure with within 50 cc of contrast. I think that's enough.
Good.
Okay, go ahead. Your procedure.
Okay, so in my mind, the lesion preparation is very important. I try to use Wolverine, the cutting balloon, to prepare the lesion. I'm not sure we can finish with without the stent or not, but for the crossing the Wolverine cutting balloon, we dilated lesion with a 2.0. Next slide. So previous. Even wiring, we didn't use any contrast. Next. I dilated with 2.0, 20, 12 atmosphere in LAD. Next. Yeah, same pressure for the diagonal. And so we can see a little bit dent in the middle of the diagonal. Next. So we did IVUS. Yeah, please show us the IVUS.
Was it NC balloon?
No.
No. Diagonal
This is
ostium is not
underside.
inflated. Diagonal ostium is not inflated.
Yeah, you're right. So, but I like to have a controlled dissection, so I like to treat this ostium with a cutting balloon. The previous report said that in bifurcation, side branch ostium is better treated with the cutting balloon.
Okay.
Okay, IVUS from the medial LAD is encircling calcium, right? the lumen size is 2.5, but encircling calcium. This is around the diagonal. This is most critical stenosis. That suddenly we get enough room on about 2.75, still encircling calcium. So, stenting is risky too, right? Distally and proximally. Yeah, almost a 3 in the proximally, but around the LED bifurcation is a 2.75. The next, then IVUS from the diagonal. Yeah, also encircling calcium. But lumen is 2.0, 2.5 at here. Even 3.0. And surprisingly, this is superficial calcium, right? Not deep calcium. This patient is CKD, but this is ostium of diagonal. Very short, about 1 or 2 millimeter, very short, tight stenosis. Hopefully, we can treat this lesion with cutting balloon. I don't know. What's your suggestion?
Actually, this imaging run is the difficulty to evaluate the vessel size, the whole
right.
calcium. So if you select the stent or balloon, what it is what size is not enough, but the heavy calcium, the outside of it is difficult to outside.
Right.
So you do better do the imaging more distally without the calcium segment,
but,
especially in the diagonal. It means it's a small size of it, but in my eye, it's the more than a 3.5. It's a quite big
I
vessel.
like to point out that this is 82 years of the female patients who mostly stay at home. So we don't need a full expansion of the stent. If we like to do that, we need to stent from the left main to this LED. That's not what we want, actually. So vessel size may be larger, but I like to avoid the edge dissection or the compromise the proximal and distal calcification.
My opinion is, I think MLD reference segment is a reasonable guideline to select balloon size.
Yeah.
Discard the vessel size, just MLD and the reference segment. Then you can achieve the similar morphology, proximal, distal, although there is a disease, but it looks fine in angio.
Yeah.
Okay.
Okay,
So which balloon size do you use?
2.75 Wolverine cutting balloon for LED, and same balloon for diagonal.
If it is inflated and it's very difficult to advance again, that's, which lesion do you attack? Diagonal first? Because which is difficult?
Actually, LED is more important, I think.
Okay.
Yeah, I try.
LED first cutting, then diagonal second cutting.
Yeah. So we have observed many studies and lab demonstration, and also the lectures about the calcification during the course, and mostly rotablation and IVL. I think we need to explore the role of a cutting balloon in this live demonstration. Still, I'm not sure, actually. I don't know. Oh, still. Okay. 가이딩 좀 잡아줄래요? Oh, there are a lot of resistance here.
Because we always call cutting balloon as rice cake in the picture.
Okay.
Oh, it's passes.
Like the sliding on the rough surface, rough asphalt. It feels like. So it's very, okay. One. Yeah, 잠깐만, stop. 약간 more distally, a little bit more distally. Okay, one.
Okay, 1.
The protocol says 1 atmosphere for 5 seconds.
Yeah.
2.
2.
Okay, 3.
3.
4.
4.
Yeah, it's a little bit distal, right? 5.
5.
And 6. 6 is nominal pressure, but it is not expanded yet. Then 8.
8.
10.
And
Yeah, maybe I try a little bit more proximally. This is not really expanded. So actually at the bifurcation, actually, it was not encircling calcium, mostly about 180 degrees. So I expected some expansion of the balloon deflation.
deflation.
I tried to be very prolonged ballooning. Yeah. Yeah, pull back a little bit more. Then 4, 8,
8.
12.
12.
Yeah, 6 is nominal pressure, 12 is burst pressure, but many doctors use a higher pressure. 16,
16.
okay. The better expansion here. Deflation.
Deflation.
You know, you have heard about the 2 trials, the COPS trial and prediction trial. They show the cutting balloon is better than NC balloon in terms of final MSA. But interesting point is that the COPS trial used a high pressure up to 18 atmosphere. Prediction trial used 6 atmosphere nominal pressure, but both studies showed a better MSA. So what's the optimal pressure of cutting balloon? We don't know. But anyway, we like to see the expanded balloon, right?
Mm-hmm.
That's why. Okay, so I'm allowed to use contrast. Dr. Hong is watching us.
Now it's time to the mix your contrast with a cell line 1-to-1. Is
Yeah. Okay.
Yeah, after diagonal cutting,
Yeah, 네.
you can do angio after second cutting
Right.
on diagonal.
you know, is a
Really?
way of the
Just
save
IVUS.
of contrast.
So to reduce contrast, just to check the IVUS
Yeah.
is enough, I think.
So always Dr. Hong refused to show us the angiography, and that this is your position is different now. Diagonal, I'm not sure.
So
You can pass
make
the
sure
diagonal.
the
Yeah.
crack is the best. Make sure the crack.
Crack, yeah. Make sure the crack, yeah. We like to see the crack. Diagonal, maybe we need a guide extension. guide 좀 잡아줘.
네.
Yeah, this is smoother.
No.
Oh, smoother. It's very good.
Maybe
Yes,
you already dilated the proximal from
Yeah. Two.
diagonal. So
There is one interesting concept
4,
to determine the size of cutting balloon. Pillow phenomenon.
6.
Pillow phenomenon.
8,
They use 275
12,
cutting balloon. The vessel size is smaller than 275. In that case, cutting blade does not expose to the outside because of the big balloon. Thus, cutting blade is sunk in the balloon like a pillow.
Do I need a kissing balloon here?
In that case, cutting
What?
efficiency
New-
is decreased.
Kissing ballooning? DCP and kissing balloon.
Yeah.
But in any way,
Deflation.
there is no indentation.
가슴 아프세요?
At least,
환자분?
inflation
아.
is achieved.
Yeah.
한 30-40분 정도만 더 하겠습니다.
Yeah. Interestingly, the patient do not complain of chest pain. So silent ischemia most likely. This is typical of old lady. Okay. Then we check the IVUS.
In the old era, Korean women are really endurable, has really a strong strength to endure stress or pain.
Yeah.
Nowadays, it changed. Young Korean women do not endure anymore, but 82 years old lady, Korean lady, can endure some kind of stress and pain.
I think even FFR has no role in the old lady patient, because the exercise capacity is very decreased, and we can make maximum hyperemia during exercise. So criteria for FFR should be lower than 0.7. This is my personal opinion.
Then you are going to IVUS?
Yeah, IVUS.
Please introduce the IVUS more distally.
More distally, really?
Yes, that is the reason why how do we identify the real vessel size?
Calcification all the way. Calcification all the way.
Okay.
There's no way to find the real
where
vessel
it
size.
is.
Yeah, just here. Okay?
Okay.
There is a clock in the
Yeah.
12 o'clock.
This is down there. I didn't touch that area.
12 o'clock and the 9 o'clock.
Yeah.
And the vessel size
This
is
start to the lesion.
or
Not treated segment.
701mm 용수 뭐예요? 응? 되게 느리네. 아, 이거 안 먹었다. 다시.
네.
Sorry. We didn't. Yeah. Again.
네.
Yeah. Pull back again.
Can you show the photo?
Okay. This is a reference.
reference.
Okay. These are to the treated segment.
Yeah, around here. This is not there, around here.
Now
This is
enter
the
the
treated
treated
segment.
segment.
This is you can have some fracture, calcium.
No.
Lumen is
diagonal.
nice, better than I
Yeah.
thought. Oh, better than I thought. Okay.
MLD is more than 2.5.
Yeah. Okay.
I think result would be a good controlled dissection or dilation with
Right.
minimal dissection plane.
Yeah. Okay.
러싱.
Flushing. Yeah, 받고. Actually, recently, Dr. Colombo is a big fan of DCB, right? Even very diffuse lesion here, tried treat end with the DCB, and he suggested FFR or DPDT should be the method to assess after the DCB, because if there is a haziness, we have a very difficult to assess. This is ostium.
Still,
A little bit larger than that. Can you measure the MLA here?
Can you measure the vessel size just distal to the diagonal
size.
branch? It's
Okay.
in my
Live,
eye,
please.
grocery is
Live.
around the
Yeah. Vessel
3.5.
size is larger.
It's a big
Okay.
vessel.
Okay, live,
Whenever you
live.
do the stent or balloon, it is not
Okay.
important. It's the actual real size is important.
But calcified lesion, you don't need to. You are not supposed to follow. This is vessel size. 2.75, 3.0. Yeah, similar.
Yeah, there is some contrast in the 9 o'clock made by the cutting balloon. Is the hematoma?
This is this part.
No, in
You
the
like to see the vessel size, so I pushed
Okay, okay.
I just cut it distally. It's the same vessel size, around 2.75 to 30.
the diagonal ostium recoiled. Thus, it is fully
Yeah.
dilated by 275 balloon, but now 1.25 still.
Yeah. The MLA,
그럼
diagonal ostium. Show us the diagonal ostium. Yeah. Here. Still, okay, 2.11 is suboptimal, but I think we can go, the LED is okay, so go to TCB at this moment. What do you think?
Okay. So
Okay. So,
please show us the angio.
Angel? No? Really? Dr. Hong, what do you think?
No, keep going. If I'm, this is my patient, I do a stent. Based on
I understand. I mean, the
understand.
angiography at this point, what do you think?
Angio moved to the Royal Victoria Hospital.
Okay. In that case, we need angiography. Okay? 많이 쏘지 말고,
네.
small amount.
네.
다이 조금만 밀고. Stop.
네.
Okay? Shut. Yeah.
quite enough.
Not enough. But DCB, prolonged DCB can make a better result. So, but I was showed enough room for the LED because this is, in this view, the smaller, another view, different, maybe?
Dr. Kwon,
So-
do you think lesion preparation of the diagonal ostium is appropriate enough?
Yeah, angiographically better, but I was
Yeah.
not enough. But I think both preparations enough for this specific patient.
You mentioned that the DCB is some fantastic and something new, but when does the drug is working in this patient? And after
calcified
the
lesion.
DCB, right now, you did just a simple balloon angioplasty alone. It's a balloon angioplasty. We have experience almost be 30 years. So
Yeah.
you mean this is just a balloon angioplasty, not the DCB. DCB is a drug is just a touch of it. So walking over the drug maybe 1 month later or the later.
Who can mention the effect of DCB on the calcified lesion? DCB 2.75 한 20mm.
I'm really curious about the DCB in the severe calcified lesion because if we do the DCB, most of drug will be delivered on the calcium surface.
But
So,
actually,
can-
subgroup
can-
analysis of calcified lesion is not so bad. No significant difference as far as I know.
I agree. So how the drug was penetrate the vessel, the surface is a calcium, so drug should be penetrate into the stone and go.
So therefore, we need some controlled dissection, I think.
It's the controlled dissection is
Right.
the
Yeah.
whole
Type 2,
area.
Type 2, and
I'm very happy to hear that dissection.
because maybe the
Yes, dissection in here
Yeah,
in the south,
this is
3
not-
o'clock, and go to the other opposite way, far away.
This is not calcified tube.
Okay.
Of course, there is calcium plaque, but there's also normal plaque tissue area. That's, I think not perfect effect, but not no effect.
조금 있는 패션이 있다, 그지? Yeah.
So how big? 275?
12. This is a 2.75. 12 atmosphere.
DCB?
Yeah.
DCB.
DCB.
More than 60
The-
seconds.
Yeah. Usually you're more than 60 seconds, our routine. So one of the good thing about, the good result about the DCB is that prolonged inflation. In the
case of-
pre-stent era, there is a study that the prolonged inflation versus the usual ballooning, so acute result was better.
So Dr. Kim, how do you think this case treated by rotational atherectomy and catheter balloon? Because the concentric 360 calcium and the length is more than
Yeah.
5 millimeters.
1 minute.
So
Yeah. Display.
before cutting balloon, maybe the
Yeah, another
rotational
DCB.
atherectomy more
디지털로
effective
밀어놓으시죠. 나오고
for the lesion
키싱하시면
preparation. What do you think? What do
안
you think?
닦일까?
Yeah, if the
들어가서
patient's
쓰니까 뭐. 하고 난
renal
다음에
function is good,
넣으려고.
예, 예.
I prefer such kind of cutting balloon or NC balloon and rotablation and stenting. But the
1.75,
situation,
20.
CKD, marginal CKD, probably GFR is less than 30 because they quote it as a major criterion for HBR. Thus, I will acknowledge the concern about in the long time kidney hemodialysis.
Actually, I don't have enough evidence to treat this lesion with the 2 dCb. You know that, but there is no one of the large trials failed in the large vessel. But even wreckage-free trial in the small vessel, less than 3.0, actually the result was quite comparable to DS. When you look at the subgroup analysis, equal to or less than 3.0, the result was, the outcome was quite the same.
Right. It's small vessel is right.
Yeah.
In the
This is
large
small
vessel, it's a different.
Yeah, small vessel was defined as an angiographic analysis and not the IVUS.
We have to move to the Royal Victoria Hospital.
Yeah,
So
I'll
you,
have to go there.
okay, it's okay. Okay, Dr.
Okay.
Gwon, we
Yeah,
are back.
welcome
You
back.
have 5 minutes.
Okay, so you treated the TCB, H side. Next. Yeah, actually we have a very nice expansion of the TCB after cutting balloon. Next. So we did, John, yeah, we did cutting the TCB. TCB is a little bit higher profile, larger profile, but it's strange. I stayed the balloon in the diagonal, then I pushed another DCB, not new balloon, just the DCB, and put another balloon and pull back. Next. The issue is that there is a possibility of overinflation and the damage to proximal, the part of the bifurcation. We say that a lot of calcification and the lumen areas are just about 3. So this technique is similar to previous, no overexpansion, so minimal overlap, kissing ballooning. Next. Next. So we did the IVUS. And yeah, I was first. 왠지 안 보여줘야 되는데. I was from the LED.
Yeah.
Play. Play. Okay, this is the distally as a reference vessel, reference calcium. This is around lesion. And the proximal to the diagonal. How about that? Can you see again? 약간 distally bifurcation 아래쪽에서. Okay, play.
Here
This
is a treated
reference.
segment. Is it?
Yeah,
Is it treated?
reference, and this is a treated segment.
Okay.
From now on, treated segment, and diagonal,
Okay.
and proximal to diagonal. So
Okay.
much better than I
2.5 to
thought.
0.
But diagonal to the back, I was. Yeah. Yeah, play. Okay. Yeah, this is a reference segment. You can see the calcium. And here.
1.5.
Not so good, right? Because this part, narrowing part is inside the plaque of LED. The previous IVUS study showed that the narrowing of the side branch is inside the plaque. The restenosis rate is low. This is a Japanese study of IVUS. Anyway, this is a very short segment of narrowing, and I'm not sure FFR will be. I don't like to check the FFR, but the impact of ischemia is not so great because a very short lesion, even vessel is very tight. And the angiography.
I believe that anyhow, the area itself, that is the fact. What is the minimal lumen area? Ask him about the diagonal branch. What is
Minimal
the
lumen area?
lumen area is just distal to the...
Yeah, very narrow,
Yes,
very small.
yes.
But length is very small, very short. there are a lot of discrepancy between FFR and IVUS, MLA, MSA, because IVUS didn't consider the length. I believe that very, very short lesion, even MLA is not so great impact.
Do you think what is the residual stenosis about the LAD, just distal?
LAD, MLA?
Residual diameter stenosis, your expectation? Is less than 30? Is the
TLR rate?
No, not IVUS, not the angiographic finding. What is the looks like the
LAD가 약간 좀 조금 더
diameter
LAD
stenosis?
stenosis.
Yes,
About 30%?
30%.
Yeah,
Okay.
30%.
I'd like to ask
Good.
that the immediate result is the less than 30, and if we deploy the stent, the residual stenosis less than maybe 10% or 5%.
And you will have dissection distally and the compromise
I
of
do not
diagonal.
comment about the dissection.
I'd like
Acute result is not sufficient. How
Yeah.
this kind of the insufficient result translate in the long-term better
Yeah.
clinical outcome?
Dr. Kim, and I'd like to ask, to hear the opinion of other panels. What do you think?
Yeah, in
This is my question.
Yeah.
Question.
Yeah, I appreciate your opinion. Okay.
in this view, we cannot see definite dissection. But to save the dye, we cannot check the lesion with another angle. Thus, I think it is very optimal balancing point to meet efficacy and safety. And diagonal os is very hard region. Thus, even though it is well expanded by balloon, sudden recoil, thus just let alone. The problem is this patient has HBR, very old age, and bifurcation lesion just treated with DB. Thus, I think early phase antiplatelet agent is very important. Thus, I recommend you to coat the coronary vessels with intracoronary bolus heparin about 500 unit, then maintain clopidogrel depth for 3 months, then followed by monoclopidogrel.
Yeah. Maybe I can try, but I can promise.
No, 3 months?
Yeah,
It
1
is
month was
1 month?
insufficient.
How about 1 month?
Yeah, I'm
Yeah,
considering
1 month increases a thrombotic event compared with 3 months without any reduction of bleeding episode.
The pre-stent era, we experienced the acute thrombosis. Thrombosis around 2 to 3% if we have a type B, type C dissection. So there is this is not B, A dissection or not B. The risk is low, I think.
I think the restenosis process starts very early phase after PCI by adhering platelet and film material. That would be a nidus for neointimal growth.
Theoretically, I agree with you.
Yeah.
But clinically, I expect the TLR rate around 10 to 20%. 80 to 90% the possibility of no TLR, at least for 1 year. So this is fair trade between the stent and bleeding risk and the TLR rate.
So, Dr. Kwon, how long will you give DAPT for this patient? 1 month, 3 months?
but please don't tell Dr. Kim.
3 months?
Because in early phase, there are multiple mechanisms to generate arterial thrombosis. As we know, mindset or stop depth 3, just monotherapy immediate after discharge, it was definitely inferior to prolonged depth. Thus, in early phase, at least aspirin and clopidogrel, different action mechanism may be required.
Considering the HBR patient, this patient was just now is a balloon angioplasty. What is the DAPT strategy in the balloon angioplasty era? 1 month is enough.
1 month. And I'd like to add that, 1 month is enough, I still think. And the final amount of contrast is 30 3 milliliter.
1 month enough after angioplasty
Yeah, but
is not based on any evidence, just arbitrary.
But
right.
you have to be cautious and nervous, cannot sleep during a 1 month. It's a mechanically
Really?
dangerous.
Yeah, I have a sleep disorder actually.
so
Okay.
I have one question for you regarding the RCA. You leave the RCA, not recognized. Is it appropriate to judge the viability for just 3 weeks?
Yeah,
Because this
maybe we
patient
can follow
have
the
a
patient
3
anyway.
weeks ago the symptom
Yeah,
QMI.
the
And,
echo and EKG is still showing a strong evidence for aneurysmal dilatation. So
She
There's a
has
small branch.
renal dysfunction, so
yeah, renal
he
dysfunction,
cannot
right?
use dye.
Yeah.
Okay. Thank you very much for your
Okay.
Thank you
Okay,
very much
thank you
for
very
your
much for
wonderful,
joining us.
insightful educational life. Yeah.
Yeah.
See you
Thank you.
dinner.
See you. Yeah.